which is around risk communication in the health sector during COVID-19. I'm sure we will have a lot of very valid information and interesting information from our different partners. My name is Chaim Rafalowski. I'm the Disaster Management Coordinator of Magen David Adom in Israel, and we are the leaders of Work Package 4, who is dealing with the operations part of operations in acute settings like disasters, like security-related incidents in No Fear Project, which is a project funded by the European Commission under Horizon 2020. We are here to share experiences. This is something that Work Package 4 and No Fear Project has been doing since the very, very beginning of the COVID outbreak. We have learned a lot, one from the other. We decided as a project to do it quick and dirty. We don't have the time. With the speed this pandemic is evolving and the situation is evolving, to do a real full lessons learned exercise and validate. We take lessons observed and we learn, we implement, and we learn from one another's mistakes, good things and challenges. And this is the way that for us at least was extremely helpful during this pandemic. We are recording this webinar, so please, those of you who don't want to be recorded, please don't turn on your cameras. We will share an edited version of the webinar by the end. The most important thing is that, again, because we are in the middle and we are not going through a formal validation process of what we are presenting through our organizations, we are presenting our own views. Please don't hold any one of the speakers on behalf of the organization. It's our experience, our feelings, our thoughts that are being shared, and this is what has been so valuable for us. So without further ado, it is my pleasure to invite Professor Francesco Della Corte. Before I invite Professor Della Corte, we are dealing with an infodemic together with a pandemic. This is the situation. And we believe that healthcare professionals have been part of this infodemic on both sides, on the affected side and the side that contributed to the infodemic in some cases, and being, I would say, the tough customer for information sharing, especially around risk management. During the webinars we've done so far, we realized that this would be an interesting issue, not just the generic risk communication, which has been addressed a lot, but the risk communication for and with healthcare personnel. This is the theme of this webinar today. Thank you for joining us. And now, without further ado, I hand over to our beloved coordinator, Professor Francesco Della Corte, the project coordinator. Please.
Okay. Good afternoon to all of you. Thank you very much, Chaim, for the presentation and for having organized this webinar that I do believe that it will be very, very interesting. I'm honored to co-chair with you this event and to see a lot of people, most of you, I know you very well. I just want to say a few words about our project, the No Fear project. It is a project that is funded by the European community that has been nominated as a EU project in June 2018, and that worked very hard in many meetings that we had. First of all, in Novara, where I live and where my university is, in Nice, in France, in Madrid, in Spain, in Rome, in Italy, and finally in last January in Israel. After the meeting in Israel, unfortunately, COVID knocked at our doors, and we started a very bad year. And our country was the first, Italy was the first that was hit by this pandemic. And after that, all European countries were involved. And we had also to change our actions inside the project to move or to take care also about COVID-19. That was the main topic that we have considered in the last year. I'm quite sure that we made a good work on that. We had a lot of seminars. I have to give my best thanks to Haim, who made a great job in organizing most of the webinars that was held in the name of the project. As you see, we are 18 members of the project, and we mix together physicians, academicians, paramedics, EMS system. We had also good relations with providers and with supporters and with the industries that are working in the field of the field of no fear content that is mainly related to in-hospital and out-hospital field. So thank again for participating. And I don't want to go further in the description of the project because I don't want to lose your time, that I think that it will be spent very well to enhance our knowledge in risk management. So thank you very much, Haim, to allow me to present a bit about the project, and we're very happy to listen to what will be said during it. So thank you all for participating.
Francesco, thank you very much. I would just add that we are contemplating a living document with the lessons observed throughout the work of the whole project through the pandemic that is shared on our portal. So please go there, look at it, and we will be more than happy to have your feedback on the lessons observed. Only together we are stronger. It is my absolute pleasure to invite Mr. Philippe Cavalier, our project officer, to say a few words. Philippe, please.
Thank you very much, Haim. Yeah, it's really my pleasure to be able to attend your webinar because, well, we have been following very closely the progress of No Fear in the last months. Well, you have been really in the light of many expectations from the European level. So we had a lot of references and a lot of information that were circulating about No Fear. So congratulations to you all because you did a great job in this very difficult year. My very short comments, actually, my very short opening is related to the fact that this network is something that we figure out really since the last 5 years, you know, with the community of users, establishment of dialogue between different actors, policymakers, scientists, practitioners, SMEs, gave us the, I would say, highlighted the need to better involve practitioners. And so it's why this networks of practitioners ideas came across, that is really how to make sure that the practitioners would be better involved, really, not as cosmetic in project, but really involved. That is being invited to participate in projects, in identify gaps and needs, validating technologies, tools, being actors in designing also research and so on. So we think that we are now succeeding to get to this point where it's now quite natural to involve practitioners, and No Fear is really focusing on the emergency medical system. So for us, it's very, very important that we succeeded to do that. It is preparing the ground for Horizon Europe, actually, because Horizon Europe will strengthen these interactions, and we will wish really to involve practitioners in reflecting with us about the design of future research programming. So it's really something, there is a clear shift in the way we will be working with practitioners. So having said that, it's also something for us which is quite important and that will be reflected in Horizon Europe, is we are all learning lessons. All actors of this crisis management are learning lessons, and it's quite hard because there is a lot of things that we have done right. Many other things have been done very wrong, and still now. But well, it's something that was not expected, completely unusual, and we are all learning resilience. But what I stress at several occasions is that this kind of event have taken place in Europe in the past and in the world. Well, many people are reflecting about the 1919 Spanish flu, but we had also pandemics like this, the Asiatic flu in 1957 and 68, 69. And if I take the example of my country in France, this is completely forgotten. I asked my parents, but well, there were something like 35 to 40,000, I think 35,000 dead people in France in 68, 69, and I asked my parents, who were 25 at the time, but do you remember that? And absolutely not. So there is no lesson that was taken up from these pandemics. It was something that was managed, well, the best they could, certainly at the time, but not really reflected into crisis management procedures. I really, really strongly hope that these pandemics will be a very strong lessons for all of us. I cross the fingers that indeed we will get out from this very quickly with the vaccine arriving, that we will at the end, well, hopefully by summertime next year, we'll be out of this, but it will not be the end of the story. We'll need to really reflect on what we have learned, and with the practitioners, really figure out how we could be better prepared and prevent better for the next one, because there will be other pandemics, unfortunately. So this is, in a way, a very positive message from one side, a slightly, well, not negative, but also realistic from the other side, just to value very strongly your work. And I pass the floor back to you, Chaim. Thank you very much.
Thank you very much, Philippe. And I'm honored to invite our first speaker of today, Dr. Dorit Nitzan, the Regional Emergency Director of the WHO European Region. Dorit, over to you.
Hi, thank you, Chaim, and thank you all. I'm really honored to be here. I heard so much about this, and when you invited me a few weeks ago, some weeks ago, I got so excited that I thought that I might miss it. So thank you very much. I'm really excited to be with you. So what I'm going to walk us through today is a bit about the health workforce and putting the health workforce at the center in order to engage, ignite, and move together, because we see the fatigue, the pandemic fatigue that is taking over many, many people, but also our professions. Next, please. So we all see that health workforce needs to be at the center, but as you know very well, there have been so many issues in that regard in many of our countries. WHO European region, we cover 53 member states and the very diverse portfolio. The Western countries were the first to hit, but the Eastern side are also very badly harmed by the virus, but also many of them do not have the capacity to deal with it. And many of them had to repurpose staff to the COVID-19 response, with many of the staff, and you'll see the data, got sick and had to go into quarantine or isolation, stress and burnout, as well as shortage of critical equipment and supplies, such as personal protective equipment that was there in the beginning for a few months and had its impact. Inadequate training we see in many of our countries, as well as labor disputes. And of course, people are people and they have to take care of their family at the same time. Next, please. There are many barriers and facilitators to health workforce adherence to the infection prevention and control, the IPC guidelines for respiratory infection. And when we looked at the evidence from surveys that we carried out, we see that local guidelines in many countries were long, ambiguous, not clear, and really not consistent. They were constantly changing and confusing people. Also, with the increased workload, fatigue, and lack of support by management team, lack of understanding, and of course, side by side with it, lack of training, but not only training on how to treat the patients, but also how to self-care and how to protect ourselves. The sufficient space, many of the hospitals, we saw that there was no sufficient space to isolate patients, and the health workforce, including the cleaning and the auxiliary staff, were not protected at all. They had to work in overcrowded situation and try to survive in that. As I said, excuse me. Oh, okay. Equipment was of poor quality in some of the hospitals, and many of the patients felt isolated, frightened, and stigmatized, and they were those who were supposed to deal and face the healthcare workers. And next, please. So to add to the already existing shortage of health workforce before the COVID itself in the beginning was kind of fortified by redeployment for COVID-19. But then what we see now is to add to this existing shortage in many, many countries, the death, the health workforce infections, redeployment for COVID-19, etc., really shrunk the availability of the health workforce. Next, please. We are following data, we are collecting surveillance data for member states, and this is using case report forms. So countries are sending us specific on each of the patients that they can, the case report forms, we call it CRFs, and they provide the descriptive information on the infections, hospitalization, clinical outcomes, subpopulation analysis, professional, etc. This we use to understand and to get better picture on the health workforce. And we estimated that around 13% of the COVID-19 cases reported to WHO are identified as occurring in health workforce. And they represent in the population, as we remember, I mean, many of us know that only 3% of them are in the population, in the wider population globally, and also in high average income countries, it's 8%. So being 13% of the cases, that means that they are really at high risk. When we analyzed the case report forms, we found out that 13% of them reported underlying comorbidities, so really not so many. 5% of cases among the health workforce required hospitalization, and about 5% of them required oxygen therapy. Overall, 0.5% of the health workforce cases were fatal, died, unfortunately. So they showed lower proportion of comorbidity, hospitalization, and death compared to the general population, accounting for age and sex differences. And these differences were especially pronounced for those aged 50 years or above. So clearly they are healthier, and yet were the first and the one that were very much hit by the pandemic. There has been substantial decline in the health workforce infections since the beginning. And when we compare the data now, we see that the good infection prevention and control actually really makes the impact, and you will see all the data later on. I don't want to waste your time here. So what we can conclude from that side is that factors contributing to increased risk of infection are the setting, the type of exposure, intensity of community transmission, presence and severity of the symptoms, use of PPE and other IPC measures. And we know that communities where community transmission is higher than other communities, the health workforce is at high risk, and they are indeed the heroes of the response. Next, please. I think I forgot to tell you next. Fine. Yes, I think, yes. So this is one of the slide that I showed you before. And next, please. So the health workforce are the heroes of the response, and engaging them is, we see it as part of the solution in the success. We think that engaging them should start from acknowledging the efforts to care for the COVID-19 affected patients and to get the communities to respect. In the beginning, we remember people were standing on the terraces and applauding the health workforce, but since then, they were forgotten in many of the countries. Many health workers have died and may have been away from home or afraid to bring the virus to their families. And these are issues that those who stay and continue to work should be recognized. They have very important roles, the health workers. First of all, self-protection and protection of their family and community, and really present the importance of the infection prevention and control. They are those who are leading the clinical management protocols and being flexible to learn and to change as needed. And they are, of course, the influencers in regards to risk communication, community engagement, and behavioral insight. Next, please. We see that the prevention of health workers' infection requires multi-pronged approach, and it includes education and many other aspects, including bi-directional communication with them. And in many countries, this is being kind of behind. No one talks in a bi-directional communication with them. So what are the advices that we give? Next, please. We are recommending that all workplaces will implement occupational health and safety, infection prevention and control with protocols that are very clear and shared with all. That in areas, and that's something that we updated through the process, in areas of known or suspected cluster or community transmission, but facilities should consider universal masking for all within the health facilities, and this is not yet in every place. Next, please. Syndromic surveillance of health workers, very important, active surveillance where the resources allow. At minimum, we recommend using passive surveillance and ensure health workers are screened at minimum before their shift for symptoms. These are important, but of course, if countries can do more, it is advised to do so. In areas with cluster and community transmission, we recommend implementing active surveillance process to rapidly identify the health workers that may have symptoms or may be asymptomatics, a minimum, as I said, before their shift, and encourage them to report on any symptoms and to avoid coming to work as needed. Next. As for testing of health workers, all health facilities, we ask that they would develop a strategy for testing health workforce for COVID-19. And we have the risk assessment tools for decision-making. Routine testing for health workers should be conducted using a risk-based approach. And as I said, we have the clear guidelines, and I'll share with you in the last slide. Next, please. When health workers are exposed, they should be encouraged to report to both occupational and non-occupational exposures, and those infected should follow the same WHO principles for discontinuing isolation, and we're really asking to ensure that they are not in touch and do not go back to work. And the risk perception is very important, and sometimes we see that risk perception is not right in some countries. We had focus group in several European countries and provided policy recommendations. This was done in some of the countries where we understood that the risk perception among health workers needs to be kind of improved. In Armenia, we worked on mobilizers, and WHO Armenia engaged influencers, including next please, including healthcare workers, asking them to wear masks and making it mandatory. And the result was that we posted their photos, we called people to join the movement, and really in Armenia, we see the change that is taking place now. Next, please. The health workers, as I said, are the most trusted source for the information, and for that we are working with them in many countries in focus groups, training them, giving them the questions and suggested answers, and try to get them engaged so that they will be able to do and to deliver the right message. Next, please. And when we do that, we found out that frequent asked questions about COVID-19, clear guidance for people with suspected confirmed COVID-19, and information about services are so important. And what we have been doing with our teams at the country level, working in groups, hospitals, also their web page, social media, leaflets, etc., to spread the word. Then next. So we also explain people that PPE by itself is insufficient, and we provide the full picture. And nowadays, we say you have to do it all. It's not one thing. We have to continue doing it at work and outside of work, but we are really promoting now, and then this is the next slide. We are really promoting now the vaccines, and we say health workforce first. These are the people that we should protect the most at the moment, followed by the older populations. So we have our timeline, and we hope to see that all countries move in solidarity. Not only one country takes care of its own. Next, in the next two slides, you can see the guidelines that we have. The first one is the online trainings that we provide. We have many more on our website in the e-learning. And in the next one, you'll see the guidance resources. These guidance resources are updated quite frequently, so I suggest to go and look at them as often as you can. And I thank you very much for your attention. Good luck and stay safe. Next and the last, yes. Thank you. Good luck.
I would like to encourage people to download the wonderful app that you have of the WHO. It's an extremely useful tool that we have used a lot throughout this pandemic, giving us a lot of wonderful resources and many questions to difficult questions that people have. And WHO is a great reference And when you want to say it's not just us, it's a global thing. So Dorit, thank you very much, and thank you for the wonderful work that WHO has been doing throughout this pandemic. Professor Itamar Gruto, who can give you some first-hand experiences on risk communication during the pandemic. Professor Gruto, please.
Well, thank you, Chaim, and thank you all for the opportunity to join you and discuss some of the first lessons, or let's say of the ongoing lessons that we have during this pandemic. I am a public health physician and working with the Ministry of Health of Israel for the last 13 years, 4 of them as the Associate Director General, and I'm also a member of the WHO Executive Board on behalf of Israel. And I would like to discuss a few issues related to challenges of community risk communications. I'm not sure I have time for all the presentation, but let's see how is it going on. So let's go directly to the first slide. So I think when we are talking about the physicians and the effects, we see all the time, if we look on the macro level, a big debate between physicians and between different professionals. So this is an example of Professor Yoram Lass, who was the Director General of the Ministry of Health in 1988 during the polio pandemic, polio event. It was Israel, in a wide polio outbreak. It was in Israel. And he was saying, as you see here, it's only influenza with public relations. In the beginning of the first wave, he was very active in the TV and the media. They used to be in all of the channels. So this is an important issue of how some physician can, a debate, like seems like there is a debate between the physician about the magnitude of the pandemic. On the other hand, please, the next slide. We can see that a lot of people who came out of the area of medicine. This one is Professor Dov Schwartz, which is, is a professor of physics, not physician. So although physics and physician is close, but still it's different, subject. So he was on the other end, he said that we should do all the time lockdowns. So he says it is a matter of 3 weeks until physician will have to choose who to save. So this was during between the third and the second and the first and the second wave of the pandemic. So we have both sides, and on this spectrum we have to live. And also I can say that many people also who work within the Ministry of Health were, some were on this spectrum. Of course, more than were close to and more reservational and but still there were still a spectrum of thoughts among the physicians, both the public health physician as well as other physicians. Let's go to the next slide. Of course, the issue of fake news was important here, and we have all the time false information, and also people are concerned about it. So this is, of course, add to instability. We are now talking about the vaccines in Israel, and of course we are foreseeing and already seeing a lot of fake news. And we also just in the Ministry of Health, our Deputy Director for Communication, she built a desk to deal only with the new fake news and also all the time fight them within the social media. Next slide, please. So we have a lot of samples to challenges because there are thousands of challenges. So I decided to give you some samples. Of course, the lockdown, and one of the major issues related to lockdown is the differential versus general lockdown. And of course, we are epidemiologists, so I'm talking with on time, person, and place. So differential could be on time. For example, we had some suggestion to do lockdowns on night lockdown or lockdown in a certain period of the week, like the weekend. So this was one kind of differentiation which did not work in Israel. We tried it once for 2 weeks in the end and weekends and did not work. People did not cooperate with this. Then we can do differentiation by person or by different sectors or different sectors of the workforce of different between looking at different sectors like schools, education system, the cultural system, sports, so everybody was when you open to one of them, then the others say, why do you open the schools or don't open all the malls? And when we open the malls, they say, why don't you close why you open the malls and not open the fitness rooms, etc. So this was also an issue of differential versus general. And the other issue is place. We're trying to identify hot areas or red cities and try to make local lockdown. And this was not working so well also in the first wave and second wave. Now it's working better, but it still is not working so good. And we see, it seems now that in Israel, we're now in the, let's say people say we're in the middle of the third wave, or the second wave did not end. And now we're discussing the issue of general lockdown again. So this is actually this differential, trying to make this differential did not work. And of course, it's very, I think in terms of risk communication, it is very difficult to deal with the public and to explain, and all the discussions that are being taken in the Ministry of Health, in the government, within the public health services, within the professional people, a lot of discussions, hours of discussion in the middle of the night. Also, Dr. Dorit Nitzan is joining us very late, almost every night, but still the messages are very, very complicated, and people are trying to look for simple messages. And in terms of the area of lockdowns and all the limitations that people are having to their own personal life, it's very difficult to explain. The second issue would be the masks. We'll talk about it later. And then the third issue I'd like to address is the issue of COVID testing. So let's go to the next slide. So as you can see, this is the situation in Israel that was during this is the second wave. You can see here in the slide the second wave. So Israel was very high in the number of cases, was maybe the highest in the world. This is also because we do a lot of tests, but still it was, some kind of a unique phase, because most of the countries in that time were very low, and Israel was, let's say, very red, while others were relatively low. So we had to face this challenge, and of course, all the time there are comparison between Israel and other countries. So this is what was when we did the second lockdown, second wave. Thank you. Next slide. So so this is when we had to go into the second lockdown. These are the pictures from the first lockdown, but on September 2020, we went into the second lockdowns as cases spikes. And I must say that we were, some of the people were very skeptic about the acceptance of the public for the second wave and second lockdown. And people also, us in the Ministry of Health were afraid that this will not work, but it did succeed, and we had stopped the next peak. The problem was that we did not go low enough, and now we have it's going down, it's going up again. So we had to maybe continue this lockdown measure for another 2 weeks, and then maybe we had more ability to control the pandemic. But this is, of course, still a speculation, because we cannot prove what I'm saying here. So next slide. The other issues is the issue of the masks, and I can show you that this when I was in the sitting in the office in the office where we were managing the all the issues, a lot of people were approaching us, and one of them was a group of people who came from the area of physics, from one of the companies in Israel that were dealing with physics, and they came with this assumption that the difference between countries that succeed and the countries which do not succeed is the issue of masks, and showing that, for example, Japan, Singapore, Hong Kong, people in and even South Korea, which are countries in the Pacific Pacific areas or the Far East area are using masks, and this is what is successful there. And this led us to the policy change, which was very also surprising at that time, and one of the first countries I think that we had mandated the wear of face masks in Israel. Which actually it was a very difficult issue also to explain to the public, because in the beginning of this situation we were saying that masks are not helping and it's even damaging, and you have to increasing the chance of being infected. So this was a big challenge, but I think we did well, because we said, okay, this was the situation at that time. We did a mistake. It was not something that we had a mistake in the beginning. This is a new disease. We don't know enough. And now we have to change into this new policy, which is still in place right now in Israel. So it's still mandatory in Israel. And then it started relatively early compared to other places I think it was in the mid of May 2020. Next slide, please. So this is also what's also the WHO finally updated the guidelines on the mask for health workers and the public in June 2020. So it was, I think, a month or months and a half earlier that we in Israel had reached this decision and put on this policy. Next slide. And this is the Prime Minister Netanyahu with the face masks as an example. Next slide. The third issue I would like to discuss with you is the issue of the testing. This is a picture taken when I was in the Corona in the Israeli Parliament, the Knesset in Jerusalem. This is a Zoom meeting taking place regarding the issue of tests, of laboratory testing. And at that time there were a lot of criticism about the Minister of Health that was not prepared to increase the load of the tests. And in that discussion, there was a big debate between me and one of the director of one of the largest hospitals in Israel, Professor Zev Rothstein, who is considered a very important person in the medical field in Israel, and he was saying that we should do much more testing, although there was not available. So, but he said we should do, and there was a big fight between me and him in this meeting. But still, I think that it was very difficult to explain, and it's still difficult to explain to the public that by testing you cannot prevent the spread of the disease. You can maybe slow it down. You can cut and stop and do contact tracing and maybe put some people into quarantine. But by testing alone, it's not enough. And in that time, there was a kind of a perception which also was developed by some of physicians and also by some politicians who use this and said, okay, if you will have enough tests, then we'll be able to overcome the outbreak. So this was also a debate, and we have, if we go to the next slide, you can see that now we are doing, and I think one of the highest number of tests per million population in Israel by far. So this is, of course, because of a lot of pressure that was put on us. And of course, this was, now we are doing, for example, more than 80,000 tests per day for a country of 9 million. That's almost 10 to million, or 10 for each million of population. So it's 1,000 for the population. So it's a lot of things. So 1% of the population is being tested every day. So you see that we have this capacity, but this did not stop the disease. And now some people come and say, why do you do so many testing? Because we're doing a lot of tests, and we have a lot of cases, and this is not a real increase in the incidence of the disease, but this is because of the tests. And so we have to look also at the percentage. And so it's also changing. So it's very difficult for us also during the time to give, let's say, very precise information about the incident of the disease. They are not all these, or they are effective, and there are a number of daily cases. This is very difficult to calculate, and we don't have something to normalize it for. And this is also an issue of the problem of maybe too much testing. Next slide, please. So if I would like to summarize the issue of risk communication response, and this is some of the remarks that we can, a lot of course, transparency is required. We are trying to do to put a lot of the data that we have in the Ministry of Health, to put it outside, to also to other researchers to use the database. We are now working on to put all the database that we have on a cloud, which will be available for all researchers to also to do and also look at the data, but also to the public. Then we're trying to be proactive. It's not successful all the time, but we have to think and maybe think further and see what's going on and what the public will do and how it will react to different measures that are being taken. The issue of evidence-based decision-making is very difficult because the evidence are not so clear, and that is because this is a new virus. We don't know enough, but still we're trying to look what's evidence-based. People also demand us to be evidence-based. When we say we have to close, for example, all the, let's say, the malls or the shops, then the people say you have to prove us that the infections are coming from these areas. Although of course it's in the sense of biological biological plausibility. Of course don't have to show and prove this, but still all the time the people are looking for proofs that where the people are where most of the people are being infected, and then to try to close them. And of course, the infections are taking place everywhere, so it's very difficult also to look for this differentiated policy. Of course, response and monitoring is important in all media sources. This is what we do also in traditional media as well as the new media. And also we have a call center which was, thousands, of course, every day. And one of the big challenges is the different communities that live in Israel, the Arabs, the ultra-Orthodox, and other different populations. This is, of course, we have to make tailored risk communication. It's not a it's not a united population, so there are a lot of different subgroups that we have to address during this response. And this is done, of course, we have a desk for Arabs and desk for ultra-Orthodox, and desk for education and things like that, so we can deal and do different communications channels. Next slide. The last thing I would like to talk about would be the issue of the vaccine, which is, of course, now we are starting the vaccination campaign in Israel. Just on Saturday, the Prime Minister will be vaccinated, and then next week we start with vaccinating the healthcare teams as well as people on high-risk groups. Next slide. So if we are looking in this, I would like to look in the past. We have a lot of experience from the issue of the wild polio virus importation to Israel in 2013. Next slide. We had a big challenge with the vaccination there. Chaim, if I have 2 more minutes, then I can show this short film. Okay. This example was during the vaccination campaign of OPV that we used in Israel, and this short film was made by one of the anti-vaccinate companies, and they were trying to see what follows next after this short introduction. Is that although the contradictions in the Ministry of Health, one said like this and the other said say like that. And so people are always time looking for these contradictions and try to use them against us. Let's skip to the next slide. So I think this was, this was a very, the silent polio epidemic was, we had to invent a rule. And I think in that issue, Israel was alone, but now we have a global problem that we have to invent new wheels to deal with this pandemic. I hope that the challenge of the vaccination campaign will go through good. I believe this will be, according to my thinking, people would like to get the vaccine as soon as possible in Israel, and hope we succeed also worldwide to spread the vaccine and get through this as soon as possible. So I wish you all the best and thank you.
We will jump directly to Professor Barbara Yuen. I would just remind our speakers, please, we're a little bit behind the schedule, so please stick to your 10 minutes. And Barbara, please.
As I'm famous to talk very, very fast, I will stick to my 10 minutes, promise.
I know.
I'm very happy about the talks before me. They gave an excellent framework for the whole challenges and problems we are facing at the moment. What I want to do is just reduce a little bit the information. I just will focus on one aspect of this whole challenge, the aspect of transparency. Next slide, please. As we all know, this is what we already heard, and what we all know is it's very important in crisis communication that we are open, transparent, fast, proactive, that we foster participation and dialogue, and the one voice policy. Next slide. What we also know and have already heard is that healthcare workers are the main sources of information for the patients. They have to inform their patients and about many, many measures, including the vaccine and testing procedures. But they are also role models. They are among the first to get vaccination. And if they don't want to get the vaccination, we have a big problem. Next slide. So let's now take out the problem of transparency and participation in pandemics. Transparency means being open about pandemic uncertainty, and that people should be told what is known, unknown, and evolving, and that response efforts may change as new evidence emerges. And then we have to tell people that we have said that masks are not good, and then we say masks are the most important thing to do. And how to explain this. And the public is generally expected to assist in mitigation efforts, so we need their participation and their adherence. And as Dr. Nitzan already said, this is one of the crucial things where many countries and many organizations fail at the moment, because participation and dialogue is not really used. We have the same experience in Austria at the moment. Next slide. So uncertainty is the main problem, because what is uncertain? The risk that the virus imposes cannot be reduced to simple messages. It's dangerous for many, not dangerous for many, but dangerous for some. The threat posed by the virus provokes contradicting messages from experts, which is a big issue, because many people don't trust experts anymore because they give contradicting messages. Some focus on the individual and see the threat as not high. Others focus on society as a whole or the healthcare system and see the threat as rather high. Some focus on the healthcare system, others focus on the economics. And so again, contradictions emerge. And scientific results change over time. What is true one day may be falsified on day two. And that's easy to understand for a scientist, but not easy to understand for lay people, about infection risks, wearing masks, immunity, etc. Next slide. So building trust in the face of uncertainty is really a big challenge. Transparent information is experienced as contradicting. Experts seem to change their point of view all the time, and this endangers the building of trust. And also the one voice policy is not easy to keep up, especially in democratic societies, where each political party has their own opinion on measures, and the media is also giving contradicting messages all the time. Next slide. There are case examples from other pandemics. One study I like very, very much is the study of Treatger and Aldi. They took SARS-1 and H1N1 in Canada and did key informant interviews with healthcare providers in order to show how difficult it was for them to give information, especially about vaccine. One of the citations is a lot of people said we're giving mixed messages. On the one hand, I'm reassuring people this pandemic isn't so bad. On the other hand, I'm saying, but you should get vaccinated. So how do you get that through without confusing people? Next slide. So what was especially difficult to communicate for the healthcare workers? It was difficult to communicate about the nature of the pandemic, about the threat posed by the pandemic, about the rapidly changing scientific knowledge. One extremely big problem was that the audience had no experience with evolving situations. So it's very difficult to explain that to somebody who's not used to that. Problems with vaccination. There was a lack of resources at the beginning. There was no general communication strategy, and there was changing priorities, who has to be vaccinated first and who next. And some looked for other channels of information, some of the healthcare personnel, I mean. Next slide. So what happened to the populations? The effects in the population were confusion about messages, confusions about leadership. The people formed their own theories and underestimated the risk, but some felt more at risk. Some desired more certainty, and others wanted authority to be more open about uncertainty. Most confusion was in these two cases about the vaccine campaigns. In the end, people became indifferent, and I guess, if I remember well, in H1N1 vaccination was about 20% of the population got the vaccination in the end, which is not very high. Next slide. So there is a model that explains what you have to have in mind if you talk to people about critical things. One is, what kind of values or beliefs do people have? The next thing is, who do they trust? Do they trust the messenger? We already heard about the importance of having a trusted messenger. They don't trust everybody. The next thing is about the participation. You have to involve people. They have to participate. Otherwise it will not work. The next thing is about confidence. They have to have a sense of self-efficacy. You have to tell them that what you are doing with your mask is really efficient. You are protecting people. And the past performance is very important. The experience they have from the past. Give me the next slide, please. Especially this knowledge and past experience plays an important role. And although individuals may not have experience with the pandemic situation, most people have experience with the seasonal influenza. And this is what they take as their framework often, also for the vaccination campaign. This knowledge is locally, personally, socially situated in ways that can influence how people interpret and negotiate pandemic messaging a lot. I talked to my parents who are 82 and 84 some days ago and asked them, do you want a vaccination? And they said, no, we don't want to be vaccinated, because when grandmother got her first influenza vaccination, she got really very, very ill. So we don't get vaccination because we will get very, very ill from that. So that's how people think about the pandemic messaging. Next slide. You can skip this slide. We take the next one. Just the next slide. Yes. So what are the conclusions? The conclusion is not, don't be transparent about uncertainty. We still have to talk to people about uncertainty. It's still the core element of messaging. But we have to be aware that coping with uncertainty is a novel experience for many people, including healthcare workers. And the most important thing is that you know that you don't have to tell everything, but what you say must be true. And it's always better to give less information in the beginning, listen to the questions that people have, and then give that information that they need. You have to adapt the message to the audience. So if you take my parents, we first have to take about this story with grandma when she got this vaccination. And then we can come into an exchange about their fears and their uncertainty. Next slide. So what we call that is the reason transparency. So you say only part of what you know and can reasonably argue, not everything. And you listen to and adapt the message to your audience. You stay in close contact and open up a dialogue. You let yourself be guided by the questions of your audience. You make control possible. In the pandemic is always about altruism, about protecting others, about voluntary action, but also you have to explain this difference between a societal perspective and the individual perspective. And you provide role models from the communities. Next slide. So we have to focus in the vaccination. For example, we have to focus on the healthcare workers first, doctors, nurses, ambulance personnel, and all the other people involved are an especially critical and difficult audience. So we have to, they have to be informed in a good way and in time. And a dialogue has to be established with them in order to find out what their questions and uncertainty there are at the moment. In many of the hospitals that we coach at the moment, they are starting up this dialogue with the personnel at the moment, which is the most important thing in my view. So the frequently asked questions of this population group are very, very important. Their participation has to be won first of all. They have to be coached and trained how to communicate. And now I guess the last slide. So they have to learn about crisis communication. They have to be coached and trained in a little bit. They have to learn to focus on the societal level versus the individual level. They have to focus on altruism and voluntary action, to focus on risk groups and use target-oriented communication, to focus on dialogue and listen to questions and uncertainties before giving detailed information, and to not use a no-risk policy. There's always a risk, and it's about minimizing risk and weighing one risk against the other. Next slide, I guess I'm finished. Yes, thank you for your attention. Just the references. I gave you a lot of references.
I'm sure they will be very helpful. I'm just concerned, Barbara, with one thing. You are asking us to listen.
Fine.
Trained.
Yeah.
So thank you so much. Sue, please.
Hello everyone, and I just wanted to start by thanking MDA for organising this very valuable webinar today. So my name is Sue Anson and I'm a research manager at Trilateral Research. My research background is in risk communication and public preparedness for different types of risk. Trilateral is also a partner in the No Fear project. However, today I'll also be presenting preliminary insights from COVINFORM, Stamina and Eunomia, which are all European Commission funded projects that we work on and that are focused on COVID-19 impact and response, pandemic planning and management, and misinformation. Next slide, please. Risk communication is such an important topic due to disasters increasing in terms of their frequency, complexity, and impact. COVID-19 is a prime example of a risk with high complexity that has had a vast impact on us all in 2020. Before I move on to focus on risk communication in the healthcare sector, I wanted to cover what we actually mean by risk communication. It can seem such a simple concept. However, there can be a lack of clarity in what we mean in terms of the scope of risk communication. The box on the right-hand side provides a really useful breakdown of what we mean by risk communication. It's an old quote, but it includes many important dimensions. The fact that risk communication focuses on the exchange of information, it includes multiple stakeholders, and it is concerned with different characteristics of a risk. Risk communication can also have a number of different aims and objectives as outlined on this slide. For example, it informs the response. We're in the very early stages of the vaccine being rolled out, and so far the response has focused on the communication of information and different restrictions. This includes communication which influences to adopt protective measures, such as wearing masks, hand washing, and physical distancing. Risk communication can also facilitate two-way dialogue and listening, which has already been spoken about. But it's important to recognise that communication is not only about one-way information sharing, but it's about dialogue and listening to understand different stakeholder perceptions and their needs. Communication can also be used to build trust in stakeholders and institutions and resolve public conflict. With COVID-19, we're seeing fear and anxiety, as well as the stigmatisation of particular groups, including healthcare workers. And finally, risk communication is also relevant to other risk governance stages, including the framing, assessment, evaluation, and management of risk. The International Risk Governance Council recommends that communication is open, transparent, and inclusive, and highlights the importance of engaging different stakeholders to assess and manage risk, and that there's also a need to understand the societal context in which the risks and decision-making is taking place. Next slide, please. Before we think about risk communication in particular, it's important to understand the concept of communication. So on this slide, we have a simple process of communication being who says what via what channel to whom with what change. And this is a process summarised by Laswell in 1948. However, this doesn't take into account the complexity of risk communication and the different factors that influence how a message is received, understood, and acted upon, which is covered in the next slide. Next slide, please. There are many different models that incorporate how risk communication can achieve different objectives and the different factors that influence the risk communication process. To make sure that I stay within the time limits today, I can't possibly go into all of these different models. However, the figure on the right highlights some of these factors, such as demographic characteristics, age and gender, social content, and risk perception that influence how risk communication is acted upon. These factors can all be considered in the design of communication. For instance, I know that there may be participants on the call today who are struggling with my accent, and I've tried to take that into account by including more information on the slides, perhaps speaking a little bit slower, and also making sure that I have written communication to support the content in these slides. Next slide, please. Now that I've provided some background information on risk communication, I'd like to move on to discuss some of the challenges faced in the healthcare sector. I know some of these have already been discussed, so I'll go through them quite quickly. But just to note that these challenges have been identified from the literature, insights from colleagues working on previous projects, including Knowinform, Covinform, and Stabina. Oh, sorry, could you go back, Chaim? Yes, this slide, thank you. So in terms of experience, I mean, Barbara's already spoke about uncertainty and limited scientific knowledge, so I won't go into that in depth, but we've also have knowledge and advice that has changed as the corona has progressed. So for example, you know, the advice on whether to take ibuprofen has changed. We also have healthcare staff that have been redeployed to new roles where they may not have experience and knowledge, which requires additional communication. In terms of risk perceptions, there are some group of the public that are actually have higher concerns about using hospitals. For example, groups that have been particularly affected by COVID-19, such as Black and minority ethnic groups, and also people with disabilities have showed higher levels of concern about using hospitals. And how hospitals can also be perceived as spreading COVID. There's also differences in how different groups perceive the risk. And some groups don't think that the risk applies to them, and they think that it's actually a concern for other groups. There's also anxiety and fear that need to be taken into account. One of the other issues identified is the stigma associated with having or potentially having the virus. Whilst the vast majority of citizens have been celebrating the work that healthcare workers have been undertaking, there's been a number of attacks. The language used can also result in stigma and attacks against particular groups. For example, the use of language such as the China virus can result in particular groups being stigmatized. Next slide, please. We've already spoken about misinformation a number of times, but corona has been identified as an infodemic because it's one of the first pandemics where social media has been used so much to provide health advice and protective measures, but at the same time, misinformation. And it's important to remember the consequences of this misinformation. It can result in injuries and fatalities, and research has actually shown already that there has been direct fatalities and injuries as a result. And additionally, there's the potential for it to reduce the number of people having a vaccine. Also with corona, it's important to remember that due to the worldwide impact, we have a global audience that are watching how other countries are impacted by the virus, but also how they're responding as well. There's also the need to build trust and manage fear. There's concerns about patients that are concealing symptoms so that they can be seen by healthcare workers, challenges around communicating while wearing PPE, the need for different messages, for example, long-term versus short-term and individual versus collective. And there's also the need to reach different segments of society. Next slide, please. We've all heard examples of how COVID-19 has impacted different groups of the public differently based on some of the factors on the right. For example, in terms of gender, women make up 76% of healthcare workers in Europe, and so are potentially at higher risk. And women also have higher caring responsibilities in the family as well. Research also shows us how those in lower income groups are less likely to be able to take protective measures such as self-isolation. It's important to note that these are high-level categories and can be broken down even further. For example, health status can include both physical and mental health. And also it's important to recognise that these factors don't exist in isolation and can be combined, creating overlapping discrimination or disadvantage. Intersectionality can help us understand the connections between different factors and how they combine to increase vulnerability. This is an area that we are starting to explore in the COVINFORM project. Next slide, please. In conclusion, here are some recommendations from both the literature and our preliminary research. It's important to identify goals and outcomes of the communication, as this will impact on the messages and channels used. Are we concerned with raising awareness and influencing perceptions, building trust and resolving conflict, providing inclusive communication, or co-designing the response with the public? It's important that to see that the public can also be active participants in the response and not just the recipient of information. To increase the effectiveness of communication and avoid confusion, messages should also be short, clear, concise, and consistent. And using multiple communication channels is so important for two-way engagement and dialogue to reach different groups and understand their perceptions, barriers to adopting recommended behaviours, and also their needs. And research can also be undertaken to understand the impact of the communication in achieving desired goals and outcomes. That's the main slides. I have some references on the next one. And also some information on the projects that I've mentioned. But thank you everyone for listening. I think I've presented about 13 years of work in 10 minutes. So if anyone wants to follow up by email, my email's on the next slide. Thank you.
So thank you so much. I have to say that we passed one test now with flying colors, and it is the consistency of message throughout 5 presentations, and we did not contradict one the other. So at least on the issue of one voice, we are okay today, which makes me really happy. So thank you very much. And our last 2 presentations will be about the field experience. And the first one would be of the colleagues from SAMUR Madrid, SAMUR Protección Civil Madrid, sorry. Paloma, please go ahead. Paloma Rey? Paloma, we cannot hear you. Paloma, you're muted. Paloma, we don't hear you.
Hello?
Now Paloma, we heard you for a second and we lost you again. Paloma, we don't hear you. Okay, what we do, Paloma, if it's okay with you, we skip to Mark from the Red Cross and then we come back to you if it's okay. Paloma?
Can you hear me now?
We can hear you loud and clear, yes. Paloma? Paloma, we lost you again. Mark, if it's okay with you, we'll go to you.
Hello, can you hear me?
Mark, are you with us?
Hello?
Hi.
Mark?
Yeah, no, that's fine. It's
So-
Paloma, you're definitely not working, right?
We'll come back to
It's not-
Paloma as soon as she solves her technical issues. And we are with you, Mark, so please go ahead.
No problem. So, great. Thanks very much, Chaim, for organizing the event. And to all the other presenters for their presentations. Like you say, there's going to be some consistency of message in this one as well, which is really good. It's been a really interesting afternoon so far. And for all our sakes, I'm hoping it will continue to be so for at least the next 10 minutes while I give my presentation. So my name is Mark South. I'm what the IFRC calls the Community Engagement and Accountability Delegate for the region of Europe. I've been working from the IFRC regional office in Budapest for the last 2 years, though since the pandemic struck, I've been working from home in the west of Ireland. Brilliant. Thanks for bringing those up. So time is pretty tight, so great. So we're going to start with a quick explanation of community engagement and accountability within the IFRC. It relates to a lot of what's already been talked about, how that applies to our work with healthcare workers, and then very briefly at the end we'll touch on vaccination and where you can find some of the tools and resources that are available from the IFRC. So next slide, please. Great. So although a lot of the principles and activities behind what IFRC calls community engagement and accountability have been around for probably as long as human civilization, really, if we're being honest, so thousands of years, but actually formally recognizing them and defining them in the humanitarian sector has been a fairly recent development, with lots of organizations, including the IFRC, doing this at the same time. And so, well, it's great that so many organizations are taking it seriously. What hasn't helped is the proliferation of different names for the same thing. Chaim, if you could click through to complete the slide, I think there's a full circle of names. I think there are about 10 of them. And the last one is the one at the top. Perfect, that's the last one. You might recognize some of these names. They mostly come with their own acronyms too, of course. And these have all been used or are being used by IFRC, UN agency and others. Most recently, you might have seen Risk Communication and Community Engagement, RCCE, which up at the white one up at the top, which has been the term traditionally used by UN agencies in epidemic responses. And so has been kind of universally adopted in COVID-19. But although there are lots of these different terms and names and acronyms, don't let that kind of put you off. There are some differences here and there, and some may focus on different specific areas, but they're essentially the same thing. And for the IFRC, all of these come under the umbrella of community engagement and accountability, so CEA. So if you can flip over to the next slide again. what does CEA mean in real terms? So most obviously, probably what we've been talking about, we seek to share information in the most appropriate, effective, impactful ways we can. That's both, for example, health information about COVID-19 prevention, how to stay healthy, how to stay safe, but also accountability information about what the National Society is doing, why it's chosen to work in the way it does, who can access services and how. It's really important that people understand what the National Society is doing and why, and that's for the broader community as well, not just the people they're working with directly. But to do any of this communication and information sharing effectively, I think this has already been touched on fairly comprehensively, but we need to listen to and better understand affected people and communities. We can do that through whatever channels we have available, be that kind of specific feedback mechanisms, hotline surveys, social media, local media, feedback from volunteers, monitoring data, assessments, baselines, whatever channels are available and most practical for people to use. But to effectively serve communities, we need to understand what their concerns and priorities are, and we can only do that by listening to them. So COVID is a really good example here. At this point, the vast majority of people know about the virus and the steps they should be taking. And it's pretty clear that for most people, the barrier to adopting safer behaviours is not a lack of access to basic information about prevention measures. It's now other more subtle, more complicated cultural and social factors. But to effectively identify and help people overcome these, we need to listen to them, to understand what their motivations are. Only once we've done that can we have the information we need to effectively help people make healthier, safer choices. Thirdly, we need to ensure that what we learn from communities is acted on, to make sure our activities are shaped and adapted in response to what we hear and see and what affected people and communities are telling us. It's the hardest part. We see it again and again. Collecting feedback can be relatively straightforward. Managing and analysing the data, compiling a report, fairly easy, but making sure that information from communities informs decision making once the institutional cogs have already started turning can be really hard. But acting on feedback and adapting how we work based on what communities tell us really is key to effective programming. The fourth point is really an overarching principle that should inform all our work, and it's that we need to support and facilitate the participation and engagement of affected people and communities in everything we do. How this is done and to what degree will vary a lot depending on the context, but the principle remains that we expect affected people and communities to be fully engaged and involved in our work at every stage of the program cycle, from inception, assessment and design, right through implementation and monitoring to evaluation at the end. So next slide, please. Another way of looking at what we're trying to achieve by integrating community engagement and accountability in our programs is that we're trying to move from a situation where we're doing to people. This might be where we have like a very top-down service delivery approach, where we simply see affected people as recipients of whatever services or items we're kind enough to give them. The next step up might be doing for, where we've taken time to find out what people need or want, and we respond to that, but the relationship is still very much us and them, humanitarian and beneficiary, if you like. And what we're aiming for is a situation where we are doing with, where we actually work with people in genuine partnership and with a far more equal relationship. So at this point, you're probably wondering when I'm going to talk about healthcare workers. For the IFRC particularly, the term healthcare workers covers an incredibly broad range of people. So from countries where national societies activities such as ambulance or blood services are integrated within statutory health services, to others where the national society volunteers don't have clinical involvement but provide practical support to health services. So for example, providing meals or staffing support for screening at entry and exit ports or support to people in quarantine. So there's a very broad spectrum of staff and volunteers who engage with the health sector, and drawing a defining line between which of our volunteers and staff are health workers and which are not it's frankly an impossible task. So for us, it's probably more useful to see national societies' role and their staff and volunteers as a bridge between the local communities they're drawn from and the statutory healthcare system. And so these principles of community engagement and accountability, which I've just been talking about, including risk communication, apply across the board. So at its simplest, if we apply this this doing to doing for, doing with diagram to healthcare workers. It means moving from doing to, which again would be a very top-down approach where healthcare workers are ordered around and deployed like any other non-human resource, through to the next step where there's maybe a higher level of consultation, and up to the final step where healthcare workers are treated and genuinely feel to be valued and engaged partners. So next slide, please. So applying those broader principles of CEA to healthcare workers means they're provided with the information they need, not just about the virus, but also about the role and strategy of the organization and where their role specifically fits into that and how what they do contributes to the overall effort. That means things like regular, adequate briefings to share updated information, not just once at the start of activities, but regularly throughout the response. It means making sure staff and volunteers are equipped with Q&A documents that they may have themselves and also which they may face from members of the public. Making sure staff and volunteers have access to and know about the Q&A documents is really important for that, as well as making sure they understand and have access to the information materials, both for themselves and to share with the wider public. The HR systems are critical in this. So making sure there are clear job descriptions, roles and responsibilities so people know what it is they're doing, what's expected of them, and how their task contributes to the overall whole. So next slide, please. It also means that as organizations and institutions, we have to listen to healthcare workers. They're our eyes and ears on the front line and know better than anybody the situation in the communities where they're working. So this means regular debriefings, making sure that healthcare workers are able to regularly share what they're hearing, learning and experiencing, and making sure that this is fed into organizational decision making. It means making sure there are other systems for support, that information lines and psychosocial lines many of the national societies have opened up to the general public are also accessible to health workers, staff and volunteers. In some cases, we have national societies who've set up psychosocial support lines specifically for staff and volunteers, and as well as providing essential emotional and psychological support. By keeping track of some of the issues being reported and the questions people are asking, this can help give her an overall picture of the situation, of changing trends, of rumors, where people's anxieties are focused, as well as gaps and areas that need to be strengthened. So similarly, effective internal feedback and complaints channels are also essential for staff to feel supported and provide feedback on areas and issues that need to be addressed. Thank you. Next slide. As with feedback from communities, we need to make sure that feedback from health workers is acted on, and that there are systems in place for feedback to be effectively logged, collated and analysed, and that these are seriously considered in programme decision making as a matter of course. Again, this is often the hardest step. One of the things we found useful in encouraging it to happen is having specific reporting indicators for program adaptation based on feedback. This is a reminder that it needs to happen and that it needs to be evidenced. If it's just a thing that's nice to do that we never report on, it often never happens. So next slide, please. So tying this all together is the need for healthcare workers at all levels, staff and volunteers, clinical and non-clinical, to be recognised as crucial partners in the response and included in decision making. And that feedback is not just collected, but that it's acted on, and that health workers themselves can see how their input, their feedback, and the expertise they gain and bring through the experience of carrying out their roles is recognised and incorporated into the decision making processes. Over such a long-term response as COVID-19, which is presenting us with an extremely dynamic situation where priorities and anxieties have changed over time, and healthcare workers, that's clinical staff and supporting volunteers, have faced extreme stress and fatigue. This engagement with and inclusion of healthcare workers is particularly important. It's been critical to make sure that they've felt both supported and that the systems in which they operate are effectively adapting to fit the changing situation. Without that, it's incredibly demoralizing, I think, for people if they feel unsupported, if they don't feel valued, and if they can see that what they're doing is not actually meeting the needs that they can see in front of them. So next slide, which is my final point about the coming vaccination efforts. And I think several of the presenters have already kind of made this point, but I'll say it again, why not? We know from pretty much every survey that's been done amongst the public that people's most trusted and respected source of information about COVID-19 is health workers, whether it's GPs or the nurse next door or somebody they know that works at the hospital. These all have a huge kind of standing in terms of the respect for the information they provide. We also know that health workers will be amongst the first people to receive the vaccine. So there's a huge opportunity, and we really reliant on health workers to be role models, to be champions in demonstrating acceptance of the vaccine and encouraging others to do the same. But this can only happen if health workers feel engaged, informed, and listened to. If they feel ill-equipped, uninformed, ignored, or taken for granted in this process, and that they have doubts about the whole thing, there is every chance that they will not be able to be the champions that we need them to be. And it only takes a handful of health workers to refuse vaccination or speak negatively about it to have a huge impact on acceptance in the wider population. So for this to work, we really need healthcare workers to feel engaged, informed, and prepared. I will finish there because I realize we're really pressed for time. The next slide is just to share links with some publicly available CEA tools, guidance, and materials, and it also has my email on there if anyone wants to get in touch. But thank you very much, and thank you for staying online this long. Cheers, back to you, Chaim.
Thank you very much. Of course, we will share the presentations at the end so everyone has access. With your permission, I will just go back to Paloma's email, and I would say, I can tell you, Mark, that in Israel, we already have those healthcare workers who are publicly against vaccination. So it's not about to happen, it's already happening.
It's happening.
Paloma, please, go ahead. Paloma Ray? Paloma? Itamar, do you see Paloma online?
I see Paloma trying to speak.
No, I don't see her.
Paloma, Miravet, if you can call her and suggest that she calls over the, here she is. Paloma?
I'm talking with her, Chaim. She's trying to fix it.
Maybe she can call us by the phone. It would be the easiest way.
Can you hear me now?
We can hear you. Oh, please. Yes, we can hear you.
Okay, now?
Yes.
Okay. Okay. Good afternoon to everyone. My name is Paloma Rey, speaking on behalf of SAMUR Madrid. Thanks to MDA for organization this interesting webinar, and also thank you all for reminding online. I will speak about our experience in risk communication during COVID-19 in SAMUR. I will start with a little background data. The World Health Organization warned about the risks of widespread infection by SARS-CoV-2 on January 30, and the first case in Spain was confirmed just the following day. Community transmission began by mid-February, and the national lockdown was imposed on March 14. By late March, Madrid became the epicenter of the pandemic in Spain, and that's why SAMUR have to adapt knowledge, practice, and procedures, and we are still working on it, from the point of view of care, logistics, and organization to address the new roles and responsibilities. Next, please. First of all, a contingency plan was developed, identifying the key risks. Among others, that plan included the suspension of all group activities, like training sessions, attendance to congresses or seminars, etc. All the scheduled training sessions were conducted online, except for the CRVN training that was considered of special importance. Another point was the rearrangement or working time for most of the healthcare workers, increasing the overtime legal limits, permitting remote working for the administrative staff, etc. It was also necessary to maintain extraordinary contact with the suppliers regarding their capability to deliver extra goods and services during the pandemic. Sometimes alternative supply options were considered, like the interchange of protection materials with other institutions, etc. Of course, coordination with hospitals, social services, police, etc. was established in an early stage of the pandemic. Middle and senior management staff used to have a meeting on a daily basis to make decisions based on the evolution of the pandemic. In order to standardize the assistance to the COVID-infected patients, several operational procedures were published. Next, please. Up to 9 procedures based on the most recent updates. These procedures had been widely disseminated through multiple ways, SAMUR website, intranet site, massive emails, and daily briefings. Next, please. The first measures were addressed on March 4th. The situation was unstable at that time, changing very quickly, and the information in the news was rapidly evolving. In terms of communication, the main objective was not just the transmission of reliable and up-to-date information, it was also provide proper and effective risk communication, offering the reassurance, not only communicating just the threat itself, but also being aware that people can perceive and respond to the threat in many different ways. We followed the rule of not speculate. I mean, if we didn't have the answer to any question raised about the pandemic, it was okay to say, I don't know. And the information has been always given in a proactive way. Next, please. Every day, a briefing is conducted before each working shift to give information about the use of PPEs, to answer questions about procedures, also to provide epidemiological update and any information in the context of the changing scenario to clear up doubts and dispel fears. Next, please. Okay, a critical point was to meet concerns about the PPEs. The greatest coronavirus-related fear is a family member becoming infected more than catching the virus ourselves. During the first wave, there were times when stock of PPEs was very low. In such situation, the healthcare workers were told that there were PPEs available for all personnel, although they should optimize the spending. The anxiety of knowing that there were PPEs left for only a couple of days was never transmitted to the daily operational staff. A strong point was the creation of a dedicated team to monitor the quality of the PPEs before their use, since we received material from suppliers we didn't work with before. Another positive practice in SAMUR was the independent purchase of PPEs, ignoring the recommendations of the competent regional health authority. Next, please. Several issues were identified as transmitters of security and confidence to the healthcare workers. The first one was knowing that the management team had a daily meeting first thing in the morning before the first briefing session to make last-minute decisions based on the evolution of the pandemic. The second one was the presence of a member of the executive staff in every extraordinary activity that SAMUR had to assume during the first wave. The incorporation of an occupational health physician from the Municipal Department of Public Health to SAMUR was another positive issue. This doctor only takes care of the SAMUR staff in case of occupational or non-occupational exposures and their follow-up. The communication of the infection rate among SAMUR staff was another strategy to transmit confidence, since our infection rate was much lower than other health services in Madrid and in Spain. Next, please. In conclusions, we can say that the main stressor for healthcare workers has been and still is the potential lack of protection material, much more than the heavy workload. In theory, information about risks should be given using an objective and realistic approach. But in practice, some stressful situations were assumed by senior managers without transmitting real problems related to the availability of PPEs to the operational staff. That's been our experience. The perception of risks is influenced by the sense of belonging to the organization and the professional experience. And the pandemic is lasting a long time, so it's necessary to maintain a fluid communication with the healthcare workers with the main objective of helping to reduce stress and keeping their spirits high. Next, please. Next, please. We can also conclude that the way leaders communicate with workers plays a very important role in how workers experience a crisis situation. Next, please. I would like to finish with a reflection on the fact that leaders also play an essential role in motivating workers and should make them feel they are performing an important and efficient work. As an example, this is a picture of our head of the unit of human resources during a briefing session, giving a motivational message to the operational teams. He said, "Thank you for your work. With this army, I would definitely go to war." And that's it. I thank you, and I wish you all a safe Christmas season.
Paloma, you have all my admiration for the idea that your leaders not just talk, they also walk the talk. And the fact you were present on every major operation despite of the risk, and the fact that it was not necessary as such is admirable. Thank you very much. Francesco, over to you.
Thank you.
Yeah, thank you. Thank you all for this very, very, very interesting seminar. I think that this seminar should have been attended also from some of our politicians and some of our epidemiologists, virologists, and clinicians that are fighting all the day on the TV shows and so on to give the right answer to the right questions. They don't succeed in it, but they are very helpful to increase anxiety in the population and also to transmit bad messages. I do believe that what has been said in this seminar is is very, very important to all of us, also to try to evaluate at least the consequences, most important in communication, especially on health, or also on healthcare workers. We passed from the first wave when we were considered heroes, and we moved to a second wave where we are quite criminals, you know, due to all these bad influences from press and the so-called experts that are giving messages that most of the time are one against the other, you know. And I think that this is able to give a bad impact on the health workers who spend most of their time to trying to solve problems. So I think that some of the lectures were were giving a very insight that were very important. And I want to thank all the speakers who brought these aspects of competence of their activities. And personally, I think that I will get most of the messages and I will bring them in my hospital community, because I think that they were very interesting for me, and they will be also interesting for my staff. So thank you very much again. I think that the No Fear project this afternoon has get the target as expected. So thank you to all the speakers, and also thank you, Chaim, for having organized this very interesting webinar. I don't know if we have time to make some questions, or if somebody among the speakers or more the attendees would like to give some questions to the group of speakers, or should we conclude here?
I think people have already other commitments, so if anyone has any question, they are invited to send it to us, and we will make the contact with the speakers. We will of course share most of the presentations and the recordings. I would like to ask our keynote speaker, Dorit, if you want to say anything before we say happy season's greetings.
No, I'm just impressed with all the work, and I've been sitting here and thinking that many of the frontline workers, those that are impacted by the decision made by others, and those that are impacted by the lack of trust that is done by many, that is created by many factors, among them health professionals and non-health professionals. I think that we have to somehow shield them and protect them, and listen to them mostly, because in many, like in our projects, I know that in the past we used to do health promotion, risk communication, but the real engagement is something that, as we heard, is coming to the scene also in heavy institutions like WHO. So I look forward for us to work together, and for me to be with you today was one of the lessons that I'll take with me back to the teams. Thank you very much, and happy Merry Christmas, Happy New Year to all.
So from the Holy Land, Happy New Year, Merry Christmas, or Merry Christmas, Happy New Year, according to whatever you celebrate. Most important, peaceful and good health. And let's see all of us, ourselves, next year with a much better year than this one. So please stay safe from all of us in No Fear. Thank you so much.
Bye-bye.
Same.
Bye.
Thanks, everyone.
Thank you, everyone.
Bye-bye.
Goodbye.
Thank you.
Happy
Thank you,
New Year.
Chaim.
Cheers. Bye-bye.
Bye-bye.
Everyone.
Happy New Year to all. Thank you very much. Bye-bye.
Bye-bye.
Bye.